Well, welcome everyone. Thank you for joining today. My name is Margaret Holland. I'm going to be your host and moderator for today's program. We will be talking about caring for the adult congenital heart. And we have the pleasure of having Dr. Michael Kwan as well as Dr. Fred Wu with us today. And we'll go around and do some introductions. Dr. Wu, can you start us off?
Sure. My name is Fred Wu. I'm one of the cardiologists in the Adult Congenital Heart Disease program here at Boston Children's. I was actually trained in internal medicine and pediatrics, and then afterwards did a fellowship in adult cardiology, and then came to Boston to do some additional training in adult congenital heart disease with Mike Landsberg and team back in 2006. So I've actually been part of the Boston Children's staff now for almost 20 years. And I run the single ventricle program within our adult congenital group.
Amazing. Thank you. Dr. Kwan.
Great. Thank you, Margaret. So my name is Michael Kwan. I'm one of the congenital heart surgeons here, primarily based out of Boston Children's Hospital, focusing a great percentage of my efforts on the care of adult patients who need heart surgery. And we do our operations both here at Children's as well as at the Brigham and Women's Hospital, which is our sister institution right across the street. And we'll talk a little bit more about that kind of distinction later. But I did my training all at Mass General Hospital for general surgery and cardiac surgery. And then I did some additional training in congenital heart surgery, both here at Boston Children's Hospital as well as at Seattle Children's Hospital. And then I spent an additional year focusing on how to care for adult congenital patients, specifically at Columbia University in New York City, before joining staff here in Boston back in 2020. So I've been here for now close to 5 years at this point.
Wonderful. Thank you so much. And just for you all, like I said, my name is Margaret Holland. I actually started out in pediatric cardiology, spent about 5 years down in the DC area working for a practice there, and then was very interested in surgery. So did adult cardiac surgery first and then came to Boston Children's where I've been for the past 6 years. Currently, though, I'm full-time at Brigham and Women's Hospital, where we are focusing on the care of the adult congenital heart patient. So this is a topic very near and dear to my heart as well. So excited to share with you all today wonderful programming. Dr. Wu, can you get us started with talking more about the BACH program?
Yeah, sure. I would love to. Thank you. I actually see some familiar names in the participant list here, so I think at least some of you are familiar with our team. But I wanted to take the opportunity to share with you a little bit about our adult congenital heart service. And for those of you who are already familiar with our team, maybe you'll learn something new about the individual programs that we're building. So the population of adults with congenital heart disease, as you know, continues to increase steadily as improvements in both medical and surgical management of congenital heart disease have resulted in improved short and long-term survival. It's estimated that currently there's over 1.5 million adults living with congenital heart disease in the United States. That may actually be a little bit of an underestimate. And of course, there's many, many more patients with adult congenital heart disease across the world, many who come to Boston as well. Can you advance a slide, please? So we've seen that reflected here at Boston Children's Heart Center, where we've seen a steady increase in our adult patient volume. In particular, if you want to click again, we've had a 25% increase over the past few years in patients who are over the age of 35. That does pose some challenges sometimes because while the Heart Center is committed to taking care of all patients with congenital heart disease for their entire lives, some of the other departments that we work with oftentimes will have a cap as to how old those patients can be. Next slide. Now, patients with congenital heart disease are a particularly special population because many types of congenital heart defects have been shown to be associated with increased risk of conditions besides the heart disease. And in many cases, these are things that cardiologists and surgeons who are taking care of adults who have acquired heart disease later in life, such as coronary artery disease or atrial fibrillation, may not be used to considering. Next slide. So it's largely due to the complexity of congenital heart disease patients that they tend to do better when they're cared for at a center with specialized expertise in congenital heart disease. This is actually a study that was done by some of our colleagues in Quebec about 10 years ago that showed that there's actually improved survival within just a few years when patients with congenital heart disease are cared for at adult congenital heart disease specialty centers compared to community hospitals or hospitals that don't have a dedicated center for adult congenital heart disease. Next slide. So the BACH program is actually one of the oldest dedicated adult congenital heart disease programs in the entire world. It was started back in the 90s by Mike Landsberg, who many of you may be familiar with. He has always been one of the leaders in adult congenital heart disease, and it was started with the support of leaders in both the pediatric and adult cardiology worlds here at Boston Children's Hospital and across the bridge at Brigham and Women's Hospital. Next slide. So since its inception, we've trained nearly 50 adult congenital heart disease cardiologists, many of whom have gone on to lead programs all over the world and certainly within the United States. And many of them are also training fellows on their own. So we're trying to put out as many adults in the world who know how to take care of these complex adult congenital heart disease patients as we can. More locally, we've had made efforts to provide outreach to the New England community so that patients don't necessarily need to drive all the way to Boston and deal with Boston traffic in order to receive expert specialty care. Currently, the BACH cardiologists are seeing patients at 12 different locations across 3 states. So we go as far north as Dartmouth-Hitchcock Medical Center in Lebanon, where we see a lot of patients from Maine and Vermont and northern New Hampshire, and as far south as Providence. We also have a clinic out at Springfield that Mike Sting does at Bay State Medical Center, and we're in negotiations to see patients at additional centers as well. So many patients have found that to be very helpful. This is obviously made possible by the huge growth of our team since Mike Landsberg originally started. So we started out with Mike Landsberg, and some of you may have known Disty Pearson and Sue Fernandez. Caitlin Joyce was, I believe, the 4th person to join the team. But now we're up to 8 full-time cardiologists as well as 8 APPs, so both physician assistants and nurse practitioners. And we also have a large dedicated office and research staff. Next slide. But in truth, the BACH team really extends beyond just those people to include critical partners of ours in obstetrics and gynecology, in anesthesia, in surgery, in imaging, electrophysiology, heart failure and transplant, and many, many more. So this is actually the slide that when we go to national and international conferences and we talk about the work that we do, this is the slide we put at the end to kind of thank everybody who contributes so much to the care of our adult congenital patients. Next slide. So one of the advantages of having such a large group is that we are able to create specialty programs to provide highly expert care for many complex conditions. So I just wanted to run through a few of those here. So this is Mike Singh, who is, again, one of my partners, also trained in adult congenital heart disease, but he's also an international expert in aortopathies and connective tissue disorders, which include Marfan syndrome, Ehlers-Danlos syndrome, Loeys-Dietz, and so forth. And he sees patients at 4 different locations and works with many of the cardiac and vascular surgeons to take care of those patients. Next slide. Mary Mullen is a recognized expert in pulmonary hypertension, both in relation to adult congenital heart disease and otherwise. She's involved in a lot of national and international research related to the care of pulmonary hypertension, and she really spearheads the treatment of both adults and pediatric patients here at Boston Children's Hospital who have pulmonary hypertension for many reasons. The next slide. So I run our multidisciplinary adult Fontan program, and that's done together with colleagues from the adult liver team. as well as from the nutrition team and exercise physiology. We are working very hard to try to get some people to come help deal with some of the mental health issues, but it is a little challenging to find people in the adult realm. The patients who come to the pediatric side of the Fontan Clinic do get seen by the cardiac neurodevelopmental folks with every visit. So far, we've seen in total about 200 patients over the past 3 years. We meet once a month. And all of these patients get a comprehensive evaluation and have a comprehensive report with recommendations sent back to their referring cardiologist. So this is just a consulting service, meaning that we don't actually take ownership, quote unquote, of any patient. So patients get to stay with the cardiologist who knows them well, but they come to see us periodically to get a comprehensive evaluation and to try to optimize their health, before things go wrong. Next slide. So Anne-Marie Valente, who is our current director, and Fernando Barona work together with the high-risk obstetrics team over at Brigham and Women's Hospital. This is Kathy Economy, who's one of the high-risk obstetrics or maternal fetal medicine specialists, and Jeannie Carabuena, who's a obstetric anesthesiologist. And they take care of patients who are pregnant with not just congenital heart disease, but all sorts of different heart diseases. Congenital heart disease actually makes up the majority of people who are pregnant who have heart disease as well. So that's sort of the bulk of what we do. But in addition, there are patients who have arrhythmias, aortopathies, connective tissue disorder, and so forth. And this program has been around for about 15 years and is a pretty high volume program that takes care of some very complex patients. Next slide. This one is a relatively new program that's spearheaded by one of our junior attendings, Dr. Amrit Misra. So he sees patients with congenital heart disease and heart failure together with the heart failure and transplant team over at Brigham and Women's Hospital. Again, this is a monthly type of clinic, and when patients come, they get seen both by the heart failure and the adult congenital cardiologist. And the purpose of this really is to make sure that, before patients get to a point where we're actually thinking about advanced therapies like heart transplant, that they're getting optimal heart failure care so that they don't proceed to that point. But then if patients do require more advanced services, it's something that allows us to get them in early with the heart failure team at Brigham and Women's Hospital. And we've been very successful with that. Next slide. We also have a very robust research program, which is run by Dr. Michelle Gerbitz, that not only helps to keep us on the cutting edge of adult congenital heart disease care, but also helps us to contribute to the science of adult congenital heart disease, really in order to improve care to adult congenital heart disease patients all over the world. Next slide. And then finally, Mike Landsberg, who started our program, actually did a really fantastic thing, which was he went back and did another fellowship in just a couple of years ago in palliative care medicine. So he's created this new and very valuable program, I think, called the PATCH program, which is in honor of Patch Adams over in that top right corner. And this program focuses on providing palliative care for adults with congenital heart disease who are both in the hospital and as outpatients. And we've really leaned on him a lot to help patients deal with some of these really stressful things that they sometimes go through. Next slide. Now, the fact that we have all of these programs on the one hand is a testament to the really incredible advances that have been made by cardiologists and surgeons that came before us and that got all of these patients to where they are now. But it also reveals the limitations of the treatments and technologies that we have. The fact is that all the surgeries and procedures for congenital heart disease that we do in children are not really curative. So patients who are surviving with congenital heart disease are still prone to long-term consequences that can involve both the heart and other organs besides the heart. And so many of these patients will go on to require additional procedures or surgeries, which is the main reason why we're here today. Next slide. So with that, I'd like to pass along the microphone, I guess, to my partner, Dr. Kwan here. I had a little joke here that we may not have written the book on adult congenital heart surgery, but we did write a book chapter a couple of years ago. So I will let Dr. Kwan take over from there.
Thanks, Fred. It's interesting. It's not just the number of patients with adult congenital heart disease now requiring surgery in adulthood that have increased over time, as Fred alluded to, but it's also the complexity. And if you kind of think back to the history of congenital heart disease care over the last century. Our field is a very young field. If we imagine back in the 60s and 70s when some of the operations were just first being invented, folks who were born with severe forms of congenital heart disease were not expected to survive into adulthood. And it was only through a lot of hard work and innovation from the early pioneers that we've now sort of totally flipped that script so that now the expectation is that the vast majority of patients who are born with congenital heart disease, even if they required multiple operations over the course of infancy and childhood, will survive into adulthood. And so the patients that we're seeing nowadays are unique in so many respects. And because of that uniqueness, it really does require a very comprehensive and specialized multidisciplinary team of doctors to really understand all the different aspects of someone's health that can impact whether or not an operation that's done, which is really sort of a hallmark moment in the journey of a patient through through their overall care over a lifetime, to make sure that those defining events, these operations, are able to be done with the greatest amount of benefit and the least amount of risk. So I just want to introduce the team that we have. Dr. Imani, myself, and Dr. Roy are the three principal surgeons that do the operations, and the vast majority of the adult congenital operations. Margaret Holland, our physician's assistant, supports us in every aspect of the patient's care, and oftentimes when we're in the operating room, she'll be available to coordinate and communicate with patients and other providers to make sure that the care is seamless and that folks are informed about exactly what's happening. Three of the other surgeons in our group, Dr. Del Nido, Dr. Baird, and Dr. Finn Thompson, also do a fair number of adult congenital heart procedures. Dr. Meyer is still around. He's no longer operating, but I'm sure that there are a few folks in this audience who've been cared for by Dr. Meyer, and we've all learned a ton from him. And so the next concept I just want to introduce is this idea of specifically why adult congenital patients require such specialized care. So I think of the complexity of an adult congenital heart patient sort of on two axes, if you will. And if you look at this graph in the x-axis, we're talking about sort of how complex someone is from the standpoint of non-cardiac medical problems that we accumulate as we age and as we grow older, even in the absence of congenital heart disease. And so that's, anything from a young, healthy 22-year-old with no other medical problems to someone who's in their 60s or 70s and has disease of the kidneys, the liver, they smoke cigarettes or have other issues that can affect the lungs, etc. And then on the other axis, the y-axis here, as I've represented it, is complexity related to how complex the actual heart disease is. So when we talk about complexity on the lower end of the spectrum, these are folks who have the normal biventricular circulation, two ventricles. All four valves are present and they're there and they're oriented and connected in the right way. Versus on the far end of the spectrum, some folks are born with just a single ventricle, or they have the two major vessels leaving the heart connected to the alternate ventricle. We call that transposition of the great arteries. And so there's a lot of complexity there that requires cardiologists and surgeons who really understand that anatomy and the attendant physiology to then form a really unique and sort of bespoke plan for how to rearrange the circulation to improve symptoms and to prolong survival, which is sort of the two-headed goal that we have for essentially every patient. And so if someone is, and so this is a concept that all centers across the country, I think, struggle with. And the way I can best explain it is that if one is relatively straightforward from the standpoint of their cardiac disease, these are patients that have typically been taken care of at an adult center, where there may not be as many specialists who understand the sort of more complexities of the cardiac disease, but that's oftentimes okay if the heart disease is not that complex. Whereas there's a benefit from having care in the adult hospital because of all the other support staff that understand the diabetes and understand the PTSD and the renal disease and the liver disease, the lung disease, et cetera. And then on the other hand, you have patients who are sort of on the younger and healthier end of the spectrum, but who have really complex heart disease. And typically those patients have been taken care of at a pediatric center, where you don't need to have a full cadre of adult specialists, but you really do need folks who understand the congenital disease along the full spectrum of complexity. What we're seeing as we've had more success over the past few decades in patients with both simple and complex forms of heart disease is that this population of patients, where they're both complex on the adult comorbidity axis as well as the cardiac complexity axis, are growing in number and growing in complexity. And so this is sort of the mission of our surgical program, is to try and develop as best we can a comprehensive program that meets the needs of all patients across a sort of two-hospital system where, regardless of where you get your operation, the cardiologist seeing you, Dr. Wu's team, and the surgical team taking care of you, that's our team, are the same. You don't have to compromise on the expertise of the people who are the boots on the ground doing the operations and managing the medical care around those operations. And with that strategy, in the last 4 or 5 years, these are the numbers of patients that we've taken care of in the operating room: 140 patients as of last September at the Brigham and Women's Hospital and 407 patients at Children's Hospital. And these are the sort of data that represent our outcomes. So as surgeons, we like to sort of grade ourselves on how well our patients are doing. One of the best ways is to see how high or how low the rate of complications after surgery is. And this is not to sort of toot our own horn, but we're quite proud of the fact that considering how sick and how complex some of our patients are when they come into surgery, that our overall survival rate after surgery is on the order of about 99%. And for those of you who know what ECMO is, it's a form of heart-lung support that some folks need after surgery. That percentage is quite low, between 1% and 3% across both institutions. The rate of stroke is also in the low single digits, as is the rate of renal failure, the need for a pacemaker, major infections causing sepsis, and pneumonia. So I'll stop there, and we'll move on into the next section of our discussion today, where Margaret Holland will field some questions and generate some discussion. But I just want to leave this QR code up here for those who are interested in learning more about our surgical program, what sort of the patient journey is like, sort of how we think about surgery, the risks involved, and how to balance those with the benefits that we perceive from surgery, and also get a chance to watch some videos and get to know me and Dr. Imani a little bit better in particular.
Wonderful, thank you. Yeah, so I'd like to transition to asking you both some questions. So based on what we learned from this presentation, it's evident we need very specialized care for these adult congenital patients. Could you both address how before coming to Boston Children's or the Boston area, what kind of care did your patients receive as adults? And did you see any shortcomings that change your practice now and led to you creating the programs that we currently have? Dr. Wu, if we could start with you.
Yeah, so I can tell you before I came to Boston, I did my my internal medicine, pediatrics, and adult cardiology training at the University of Minnesota, which is actually where a lot of heart surgery initially was kind of developed with cardiopulmonary bypass and so forth. The issue that that we really had there was that even though there was a lot of early there were a lot of patients that we were seeing that were early recipients of heart surgery, the volumes were not nearly what they are here and what I see at Boston Children's Hospital. So it was much fewer patients with congenital heart disease, and there was no dedicated adult congenital heart disease service. So I actually got to know a lot of these patients as a fellow, because I was seeing them together with one of the interventional cardiologists who was sort of like the de facto adult congenital heart disease specialist. And the biggest difference that I saw there compared to what we do now, is, in Minnesota, when we were seeing these more complex patients, like we didn't really have a whole lot of, we were sort of like, the two of us were kind of like the experts. There weren't really a lot of people for us to go to for, advice and counseling on how we might approach these more complex patients. And that's really been one of the, I think, biggest advantages of a program like ours here in Boston, at Boston Children's Hospital, is that, we have such a breadth and a depth of expertise here at this hospital that when patients come who have very complex medical issues, because again, it's not just related to the heart. A lot of our patients come, they have lung disease, they have liver disease, they have kidney disease. And, we're trying to find ways to get them through a pretty big operation without, suffering any further harm to their kidneys and, without getting any infectious issues. And so it's actually been very helpful that we're able to pull in the expertise of our colleagues from, say, from pulmonary or from the liver team or from the kidney team, to see these patients with us beforehand, and to have a plan in place so that we know how to try to optimize their health going into surgery, how we have strategies, which, oftentimes Dr. Kwan, Dr. Amani have ideas of how we can try to make the surgery sort of as less, sort of the least possible stress on them as possible. And then how we can sort of proactively take care of them afterward, to sort of look out for these things and try to nip them in the bud before they become bigger problems. So really, I think the biggest part of it is just having, this expert community, having more experience with more complex patients. That's really been the biggest difference between here and where I trained before.
Wonderful. Thank you. Dr. Kwan.
Yeah, I think one thing that's just interesting to note is that across the country, about 95% of adult congenital heart surgery is done by surgeons who don't have any or who have not had dedicated congenital training, meaning those who primarily operate on non-congenital cardiac surgery patients and will sort of dabble in the congenital aspect of things at their local institution based on the problems that sort of come through the door. And what we learned over the course of analyzing a bunch of studies in the past 5 to 10 years is that in the same way that patient survival and patient health indices are improved if you have specialized care by an adult congenital cardiologist, likewise, the survival and the outcomes are improved after surgery also, if the surgical team taking care of you were formally trained and primarily practice in a congenital environment. So that the difference is that those surgeons with the training are doing sort of congenital heart surgery front to back all day, every day, from the neonates, the babies, to the kids, the teenagers, and then also the adults. And so, when Dr. Mani and I approach a patient who's had, 3 prior operations, we can look at that patient's history and say, we know exactly what was done because these are operations that we also do in our own practice. Meaning, for example, we took care of a patient who had narrowing of the pulmonary arteries after an arterial switch operation done 30 years ago. And that's an operation that we did on a Thursday. But the previous day I had done that operation, the arterial switch operation, on the Wednesday. And so there's a familiarity and a comfort level and an expertise that comes when you have a group of surgeons that's really sort of focusing in and has a comprehensive understanding collectively of what kinds of issues are involved. And we've had the good fortune of being able to receive some patients who, even though they've had some procedures done elsewhere that didn't go quite according to plan, we were able to identify what the problems were and then sort of reverse course by doing the definitive operation that reversed the problems from before, and then improve the circulation even further. So I think that in a sort of circuitous answer to your question, that over time what we're seeing is a greater centralization of congenital cardiac surgical care in these sort of centers with high volume and high levels of training and expertise amongst a team of surgeons, not just individuals who have maybe seen your condition once or twice over the course of their careers. So I think that makes a meaningful difference, and we're hoping to see more of that.
Now, speaking of having prior surgical operations, many patients wonder, how does that buildup of scar tissue affect a future operation or even just the basic function of their heart and their health?
Yeah, that's a great question. So, when someone is having their first cardiac surgical operation, there's really no scar tissue inside the chest unless there's been a prior infection or some other issue with inflammation. And so the time it takes to get into the chest, to expose the heart, and then connect someone to the heart-lung machine is relatively minimal. It can take anywhere from just 30 to 45 minutes. Now, human biology has an interesting feature, which is that anytime a cavity inside the body, which is normally not exposed to physical manipulation, is then exposed to physical manipulation, a layer of scar tissue forms sort of on all the raw surfaces that have been exposed to that. And so the second time the surgeon goes back into somebody's chest to reopen the chest, generally speaking, what we see is that the heart is stuck to the chest wall, the lungs are stuck to the heart, and everything's stuck to each other. And that includes the aorta and the pulmonary artery, and all those blood vessels that bring blood to and from the heart. And so it can be a significant challenge to get back in safely without injuring any of the structures. I liken it to trying to Um, if you're at an archaeology site trying to dig out a fossil from the sandstone with these instruments without damaging the fossil itself. So in many ways, that's what we're trying to do is we're trying to get back into the chest safely, navigating and dividing the scar tissue that's got all the organs stuck to each other without injuring those organs. Approximately 2/3 of the patients that we operate on who are adults with congenital heart disease have had prior operations. And so it's quite important that, that we're able to do that safely. We have a technique that employs the use of a special retractor and an endoscopic camera that allows us to actually look behind the breastbone and separate the heart from the breastbone entirely before even dividing the breastbone so that the chances of injury to any of the structures behind the breastbone are minimized.
Wonderful, very helpful. Thank you. Dr. Wu, talking more about the BACH program, can you talk about specific examples of how your team really balances both the physiological, the cardiac, neurological, psychosocial factors in taking care of an individual with congenital heart disease?
So, I mean, every patient that comes to us is different. They're unique in multiple ways. So, of course, everybody's heart disease is very different, even if nominally they have the same, underlying heart defect. But all their entire medical picture sort of differs as well. So we kind of have to, we treat every single patient as an individual when they come, and there are certain patients where, if they're being considered for surgery or other procedures, if they tend to be more complex, we have a forum or a venue where we can bring those patients up for discussion with our colleagues. And so that's something that we do once a week. We have something that we call our BACH surgical conference, and that's attended by, everybody within the BACH team, but also by usually Dr. Kwan, Dr. Amani from surgery, Dr. Roy, and usually we'll have electrophysiologists there. We'll have the interventional cardiologist there as well. And that's because everybody brings a different areas of expertise to the table, and sometimes it actually turns out that there may be specific approaches that we haven't even thought about that might allow us to avoid surgery altogether, or that there might be certain things that we can try before we even resort to an intervention that the primary cardiologist may not have thought about. And so that was actually something just very recently. For example, there's a patient that I'm seeing together with Dr. Kwan, who was referred to us specifically initially to try to see if they could get a interventional procedure to repair a valve, and unfortunately they were not a candidate for that. And so we brought them to this conference to kind of discuss the surgical planning because it was a patient that had a lot of medical issues, including pretty significant kidney disease, obesity, liver disease, some cognitive issues and social issues there as well. And in that particular case, we had our social worker involved and who was helping to kind of deal with transportation and decision-making issues and so forth. So again, that's the sort of thing where when we have these patients with multiple and complicated issues, we can bring in a lot of our colleagues to sort of help support specific aspects of their care. And in this particular case, I think we were able to make a pretty good plan for surgery, and that patient hasn't had surgery yet, but I think I'm certainly much more confident that he'll do well than I was before we had that discussion.
And speaking of some of those elements that I heard you mention, so weight management, that's actually a question that someone had proposed to us to talk about on this webinar. So how do you optimize someone with congenital heart disease as an adult as it relates to weight management? And then after that, I have a question about some pharmacology as well.
Yeah, I mean, it's actually really a very interesting time as far as optimizing weight for our patients. We do know that obesity is something that's a big problem among the general population, but we are seeing it more and more commonly, even with patients with complex congenital heart disease, and that can be difficult because obesity can be associated with increased stress on the liver. It can increase the risk of arrhythmias and diabetes, and affect the kidneys and so forth. So really with all of our patients, even before when they're doing well and before we're starting to think about other interventions, that's something that we try to work with patients on at a very early stage, is just trying to optimize their overall lifestyle. Now, I always tell people that, looking at things like BMI is really a very blunt instrument. I try not to get too focused on, what their BMI is and so forth, because we all have very different body types. But, typically we just want to make sure that patients are, paying attention to make sure that they're getting an appropriate amount of physical activity, because in many types of congenital heart disease, physical activity, maintaining physical activity at an early age is really one of the best things you can do to maintain your overall health and prevent a lot of these complications. And then, of course, there's the issue of diet. I think nowadays with a lot of people who are going to school and working and taking care of kids and stuff like that, it's really easy to sort of lean on convenience foods and a lot of those things that aren't very healthy. And so that's part of the reason why we try to work with the dietitians with many of our patients early on to get them, on a healthy diet, which, helps to reduce the risk of becoming overweight, but also reducing the risk of diabetes and liver disease and so forth. But nowadays we have, a lot of really interesting new medications, which are proving to be much more effective than some of the tools that we had before. We certainly don't jump to medical therapy as our first option. But for some patients who have really been doing all the right things and finding it difficult to lose weight, we've been working more and more with the primary care doctors and some of the weight loss clinicians over at Brigham and Women's Hospital, to try some of these medications. And so, like 5 years ago, 10 years ago, there were some new oral medications that came to market, things like topiramate and I can't remember all of the other ones, which, had some moderate success. But, some of these new medications like the GLP-1 agonists have really shown to be very effective in reducing weight and reducing cardiovascular mortality as well in some of these studies. So that's something I think we're still learning more about. But, there's definitely tools that we have to sort of help patients, to try to get to healthy weight, especially when we're thinking about surgeries where, obesity can increase the risk of complications and infections and so forth.
Yeah, we're actually doing a study to better understand the impact of obesity on the risk of complications and mortality after adult congenital heart surgery. So hopefully within the year or so, we'll have more concrete data to sort of be able to quote and say, yes, there is a scientifically proven benefit to optimizing one's weight as much as possible before going to the operating room. But we also balance that against how urgent the need for surgery is. And if it's someone who's got very severe symptoms and in whom cardiovascular exercise is really not possible based on how sick the heart is, the presence of obesity we would not consider to be a reason not to offer surgery. Only in those cases when surgery can be safely postponed for a period of time during which someone can try to get in better shape, and with the use of some of these medications that Dr. Wu mentioned, can really sort of get the most bang for their buck in that period of time. We have had success, particularly in the past 12 months or so, with some very dramatic improvements in patients' overall risk profile by the time they get to the operating room. So that's something that we'd be happy to discuss with patients who are in that situation.
Great, thank you. And speaking of medications that are available to patients, can you just talk very briefly about, we'll watch daily programming and see ads about various heart medications that can be helpful for a standard adult cardiac patient. Are any of these applicable to a congenital patient?
Yeah, that's actually a great question. I mean, they certainly do a lot of direct-to-patient advertising these days, and so we do have patients who come to us with specific questions about medications. It's actually quite challenging, and it's an area of great debate among those of us who take care of adults with congenital heart disease because, granted, most of those, a lot of those medications that people may be talking about, there's these medicines called SGLT2 antagonists. Examples of those would be Farxiga and Jardiance that, we see commercials for a lot. And there's certain kinds of anticoagulants like apixaban that, which is Eliquis that shows up in commercials a lot. A lot of those things, are very effective and they've been shown in studies to be beneficial to to specific groups of patients. The problem I think is that despite the fact that the number of adults with congenital heart disease is certainly steadily growing, it's a very diverse population. Again, there's no two patients that are the same, and it can range anywhere from somebody who has atrial septal defects or ventricular septal defects that we consider to be pretty simple types of congenital heart disease to very complex types of congenital heart disease like hypoplastic left heart syndrome, and things like that. So not a lot of studies have actually been done on those particular new medications in people with congenital heart disease. So, we don't really have the same weight of evidence specifically for our population. And you have to be careful about extrapolating from the studies that have been done in people who have heart failure because they had, a massive heart attack, or people who had heart failure because they have, stiff ventricles who are 70, 80 years old, and then trying to apply that, assuming that medication is going to work equally well in a 30-year-old, who's had heart surgery 3 times.
Right.
So we certainly do use those medications. I think, we sort of have to be very selective about it and think about like what's the actual pathophysiology of why this person, might benefit from this medication in the first place. And I think if it makes, if it makes sense from a physiologic standpoint, then, we certainly do try those medications because at the very least, we know that these medications are safe and well tolerated. Otherwise, they wouldn't have been approved in the first place. But the real question is whether they can be effective for the purposes that they're used in other types of heart disease for people with congenital heart disease. And that's something that we don't really know. We are starting to do more research into these medications specifically for congenital heart disease or certain subtypes of congenital heart disease to see if they work. But that's definitely something that patients need to talk to, their primary cardiologist. And those they're certainly on the table, but we can't, sort of paint it with a broad brush and say that these are good for everybody.
Yeah, and I think it underscores the importance of having a dedicated congenital cardiologist following you on a regular basis, so that rather than sort of applying a one-size-fits-all sort of medical treatment regimen, which I can imagine can be tempting to do, really sort of individualizing the medical therapy in a way that sort of respects the mechanism of why someone's heart is sick. If you have 2 cars on the road that are both not doing well, the reason for one car not driving well might be very different from the other, even though the net result is the same. And so, looking under the hood and really figuring out exactly what the mechanism is of dysfunction, whether that's something that needs to be treated with medicines, or whether it's something that medicines alone can't really definitively treat, and then you have to talk about going to surgery. That's the expertise of the congenital cardiologist to be able to make that determination and recommendation to then go see a surgeon and talk about what the surgical options are.
Great. Now we're about at time, but Dr. Kwan, do you mind just taking us through a quick tour of the 3D modeling simulator that is unique to Boston Children's?
Yeah, I'd be happy to. Let me just bring up this screen again. So just as an introduction to some of the more innovative things that we've been doing, this is a slide that just sort of shows the full spectrum of the types of heart disease that we are treating in the operating room. Everything from aortic valve disease to Epstein's anomaly in the tricuspid valve, pulmonary valve replacements, pacemaker and arrhythmia surgery, mitral valve surgery, atrial septal defects, ventricular septal defects, patients who've had prior surgery for transposition of the great arteries, those who have abnormally located coronary arteries, and those with single ventricles disease that have required Fontan palliation. So it's really the full spectrum. And as the patients, and this is again the same theme, as the patients have grown more complex, the operations that we do have also required more complex rearrangements of tissues and sort of three-dimensional manipulations in order to maximally improve the performance of the circulation. And so with that in mind, what our group here at Children's has really focused on, this has been led by one of my partners, Dr. David Hoganson, is the creation of three-dimensional electronic models that we can use to really form a much clearer picture, mental picture of what we're going to expect to see when we actually get in there, so that going into surgery, we have a much clearer plan of exactly what size patch we need to implant or how much tissue we need to remove. This is an example of someone with scimitar syndrome, which is when the veins draining the right lung all come into an abnormal location and need to be rerouted. And so with this 3D modeling technology, we can take someone's CT scan or MRI and create this model where we can then add or subtract different chambers of the heart so that we can focus on seeing the particular structures of interest in a much more meaningful way. And you can sort of literally fly through the chambers of the heart like Dora the Explorer and look on the inside as is being demonstrated on the video right now. And the explanatory power that this type of technology has for the practicing congenital heart surgeon is really night and day compared to what we had in the past, which is just two-dimensional flat images of a CT scan or an MRI. And so this has allowed us to do things like plan valve repairs by looking at valves very carefully. This is an example of a patient's aortic valve where there was a small gap in the center. And by making measurements and performing analysis of this 3D model, we were able to repair this valve rather than having to replace the valve, so that the patient could hold on to their own native valve tissue rather than having it replaced with a prosthetic, which we can always do. But if we can repair it and have a successful repair that's also durable, that's generally better because it's living tissue and it's your own tissue. This is the mitral valve, another one of the 4 valves of the heart that we performed a similar analysis for to be able to repair that valve rather than having to replace that valve. And with this technology, we've been able to reduce the rate of what we call residual lesions or valvular problems with the valve, either too tight and narrow or too leaky, down to about 3.6%, which is on par versus arguably better than what most programs would be able to quote you for in terms of the success of the tissue arrangements that we do over the broad spectrum of congenital heart disease across 4 valves, across the multiple different vessels that come into and out of the heart, across different types of septal defects that we treat on a regular basis. So we found that this 3D modeling technology has had a quite profound impact on our ability to confidently tell a patient that, yes, we can have a very high chance of success at repairing your defect, and by in so doing improve improve the circulation in a meaningful way.
Wonderful. Thank you for that tour. We are at time, so I would like to close. Dr. Wu, I'm sure many of our participants are wondering how can they participate in the BACH program and meet you and your colleagues?
Yeah, so we have a couple of different ways you can kind of get connected with our program. What a lot of patients do who sort of find us on the internet is they just call our office directly and speak with our administrative assistant, and we can take the information, get information from whatever center they've been receiving care at before, because it's always important for us to see their prior medical records. It's not critical, but it definitely helps a lot. So that number is 617 355-6508. The other thing that people can do is, I always encourage people to talk to whoever they're taking, who's taking care of them now, and they can initiate a referral, either their PCP or their referring cardiologist, and then get all the records sent over that we need so that the patients don't have to deal with that themselves.
Wonderful. Thank you.
In addition to that, if you're a patient who's out there in the community and your home cardiologist has sort of already identified the need to go to surgery in the near future, you could also reach out to our surgical coordinators at the following number, 857-218-3914, and we can set up a surgical consultation also. And then we could, and in that setting, what we do is then the surgeon will then involve one of the cardiologists from the BACH team so that we form a team and look at it together.
Wonderful. And I'd like to remind participants that you can find the Boston Adult Congenital Heart web page on the Boston Children's page, linked there. And this recording will also be available on our Boston Children's YouTube page. So if you'd like to refer back to it, it will be available there. Thank you both so much. Thank you, Dr. Kwan. Thank you, Dr. Wu. This was a wonderful conversation.
Thank you, Margaret. Really appreciate it. Thanks, Fred.
All right. Thank you all for joining.
Join the page. Thank you.